Live. Take. Hello student, good evening to all of you. I hope I am clearly visible and audible at your end, and very good, very good. Dr. Sidhu, Dr. Anas, Dr. Pokhrel, Dr. Sikdar, Medicos Constellation, my God. So, thank you so much for joining. I hope I am visible and audible at your end, right? Okay. So, today's session, as you know, the important one-liners of every subject is going on in this month. So, today we are going to discuss the most important one-liner in physiology, right? So, this is just to boost your confidence for the upcoming exam, okay? And this one-liner I have made in such a way that almost all the recent questions which has been asked in NEET entrance examination has been covered up, right. So, this important one liner of physiology is based on the PYQ for the last 3 to 5 years. So, the type of question they are asking nowadays, those questions, those one liner I have kept in this session. And most of the one liner, when I was revising, when I was preparing this one liner, most of the one liner is a simple one, right. So, if you look at the NEET PG question, particularly for physiology, for the last 3 years, questions are not very difficult. They are based on the simple principles of physiology. So, my advice also, don't go into the very details of physiology for the NEET PG per se, but for the INI set, you have to go into a little bit deeper. Okay. So, in NEET, you have to remember that most of the questions will be based on the clinical scenario. So, for physiology also, whenever you are getting some applied aspect, try to read those applied aspect carefully, okay, because the questions are going to come from those applied aspect of physiology only, right. So, now we are going to start this one liner. So, if you know the answer, you can try to type the answer in this chat box, or you can just listen, or later on you can get the PDF. If you are not getting, you can contact me. So, I will provide the PDF for your quick revision. So, that is the little introduction before this topic. So, now we are going to start this one liner of physiology. So, first we are going to start from the general physiology one liner. So, here the first one liner is the single liner is the baroreceptor reflex is an example of which control system. So, I believe this is one of the easiest question. All of you can answer that the baroreceptor reflex, we know that two types of control system are there, positive feedback and negative feedback, and this is typically of the negative feedback type of control system, negative feedback type of control system. Okay. So, obviously, this is for controlling the BP. So, when the blood pressure was increased, the baroreceptor will try to decrease the blood pressure. Obviously, the question is not very clear. You can say the BP is consuming the answer, but according to the MCQ, the options was the negative feedback, positive feedback. So, baroreceptor is there for controlling our blood pressure, and which kind of blood pressure control mechanism? Baroreceptor is a kind of short term control of blood pressure mechanism. Short term regulation of blood pressure is done by the baroreceptor reflex system. So, this is a negative feedback control system. Along with that, I believe you also know that the baroreceptor, okay, what kind of receptor there, that has also been asked in recent question. So, this is a kind of stretch receptor. Okay. So, stretch receptor is also known as the mechanoreceptor, also known as the mechanoreceptor. So, this information you have to remember for your MCQ. Now, the next question is the in negative feedback, the feedback gain is infinity in which control system? Could you tell me the answer of this? Infinity negative gain. Okay. So, we all know that the gain of the control system is what? Gain is correction upon error, correction upon error, right. So, whenever the error is absolutely 0, means after full correction there is no residual error, then that control system will be known as the infinity gain control system, and all of you are giving correct answer that it is the kidney. Okay. When kidney is regulating, when kidney is regulating our blood pressure and blood volume. So, in this condition, Okay, so kidney is regulating your blood pressure and blood volume. This kind of regulation is a part of the long-term control of the long-term control by kidney. But these are the typical examples of infinity gain, because meaning of this infinity gain is that if you allow kidney, okay, or if you give some time to kidney, kidney can control your blood pressure and blood volume with 100% correction without any residual error. Means whenever there is disturbance in the blood pressure or blood volume, kidney can correct that disturbance without any residual error, without any residual problem. So, that is why the gain is infinity in case of kidney, right. So, this is past 2 line. Then next is that there was another question that feed forward control system is seen in regulation of. Okay. So, one of the option you have to choose, but here I have given all the feed forward control system regulation. So, you do not have to answer here. So, thermoregulation, I told you in my classes repeatedly that it has feedback control system also, as well as it has feed forward control system also, feed forward control system also. Similarly, increase in heart rate and respiratory rate even before the start of the exercise, and we say that this is due to the psychic stimulation. Psychic stimulation. So, this kind of increase in heart rate or respiratory rate even before the start of exercise is a kind of anticipatory control system, and that is known as a feed forward control system. So, feed forward control system means, I believe all of you know that feed forward control system means it is the system which is also known as the anticipatory control system. Means it can predict that some kind of disturbance is going to happen in the system. So, it is taking some measure to correct that disturbance ahead of the right, ahead of the disturbance. So, this kind of system is predicting that some kind of disturbance is going to happen, and it is taking precautionary measures, and this is known as a feed forward control system. Like for example, your heart rate and respiratory rate is rising even before the starting of exercise. Whenever you are thinking that you have to start the exercise, that thinking is stimulating the heart rate. So, that kind of stimulation is known as a psychic stimulation. Similarly, the cephalic phase of gastric secretion. Okay. So, secretion of acid in the stomach even before the food is entering in the stomach. When you are looking at the food, when you are chewing the food inside your mouth, gastric secretion is happening. Receptive relaxation, stomach is relaxed even before the entry of the food inside the stomach. So, whenever you are swallowing the food, that time the stomach will relaxes. So, that is stomach is taking precautionary measure. And we also say that cerebellum has one kind of feed forward control system, where the basket cell or stellate cell inhibit the Purkinje cell. This kind of inhibitory control system in cerebellum is also known as the feed forward control system, right. So, these are the things that you have to remember about control system. Sir, FMG के लिए है क्या? Obviously, this is also beneficial for FMG, that is 100%, there is no confusion in that, it is beneficial for the FMG also. Okay. Now, the next one liner. So, this is basically not a one liner, multiple lines are there, but this question was asked initially, but this is a very simple question, very simple question. So, anybody, if you look at the stem of the question, you may get frightened that long stem, but if you look at during the experiment, everything has been given, and the electrolyte measurement has been given, and sodium is 10 milliequivalent per liter, potassium is 140 milliequivalent per liter. So, this is which kind of fluid compartment, ICF or ECF, that is they are asking, right. So, very simple, we all know that the potassium is very high inside the ICF. So, this is typically of the ICF. ECF, we know sodium will be more or less 140 milliequivalent per liter, and potassium will be 4 to 5 milliequivalent per liter. So, that is the typical composition of the ECF, extracellular fluid. So, this is the answer, ICF, right, no problem here. Now, next question. Okay. So, Aniket, for you, I think this is not the session, but you can watch the video, whatever is recorded video is there, and you can also join the Prof Edge. I know you know that there is a online lecture classes is going on in the PrepLadder platform, that is known as a Prof Edge, where I am taking online live classes for the first year MBBS, right. So, that will be hugely beneficial for you. Okay. And you have completed your second year week in physiology. So, that is best of if you listen the recorded video lecture which is there. Okay. Now, here anybody, could you tell me the question? Could you tell me the answer here? So, here they see several fibrous protein in the cell, and they are the stable stands, and it is giving tensile strength across the cell. So, this typical description is given for the cell cytoskeleton. Cell cytoskeleton, right. Now this cell cytoskeleton, they are of two types. One is known as the stable or static cell cytoskeleton, and another one is known as the dynamic, okay, or unstable. So under this dynamic, microtubule is there and microfilament is there, and under this static is intermediate filament. So intermediate filament is the answer of this question. So here the answer of this question is the intermediate filament. Intermediate filament. So why intermediate filament? So intermediate filament is a kind of stable cell cytoskeleton. Stable cell cytoskeleton means, suppose the cell growth is happening, cell is enlarged in its length. Intermediate filament is not going to change its length. It is a fixed structure. And if I give on examples of intermediate filament, suppose I am saying cytokeratin, cytokeratin, okay, so wrong spelling, cytokeratin is an example of intermediate filament, or vimentin is an example of intermediate filament. Then you know this cytoskeleton, cytokeratin is a marker of epithelial cell. Okay, yes, so keratin, your desmin, vimentin, okay, glial fibrillary acidic proteins, all of them, they are the examples of intermediate filament. Genong is writing that various cells contain various types of intermediate filaments, and altogether 70 different types of intermediate filaments are there, and these intermediate filaments acts as a cellular marker. This structure is so stable inside the cell that if you are able to identify this intermediate filament in a particular cell, you know that the cell is originating from this epithelial cell. Okay, if you are getting cytoskeleton positive for a cell, then you are 100% sure that the cell is originated from epithelial origin. Okay, similarly if you are getting vimentin, you know all these things are different intermediate filaments. So answer of this question is the intermediate filament. Microtubule and microfilament, they are dynamic in nature. They can increase or decrease their length according to the cell growth. So here another thing you have to remember, that the microtubule is composed of alpha and beta tubulin. So this is the subunit of microtubules, and the microfilament subunit is G-actin. G-actin is the subunit of microfilament. So these are the important point that you have to remember. Okay. Now the next question, Gibbs-Donan equilibrium is mainly maintained by. So Gibbs-Donan equilibrium, this question has been asked in NEET exam only. So answer is protein. The option which was given, answer was protein. So protein means, basically you have to remember, large impermeable ion, impermeant ions. Any large impermeant ion, if it is present in the cell, then that impermeant ion will causes Gibbs-Donan equilibrium. Okay, that impermeant ion will alter the concentration of the permeant ion in the cell, and this is known as the Gibbs-Donan equation or Gibbs-Donan equilibrium. Okay, so protein is the answer of this question. Next question, potential developed due to free movement of diffusible ion. So we know that whenever the ions diffuses freely through cell membrane, there will be development of a potential, and that potential is known as the equilibrium potential. Okay, equilibrium potential, which is also known as the isoelectric potential. Isoelectric potential, and this isoelectric potential is calculated by, so the answer of this question, calculation is done by which equation? We all know that it is the Nernst equation which is going to calculate this equilibrium potential. Got it? So potential developed due to free movement of the diffusible ion is calculated by Nernst equation, because the potential which is developed due to movement of the ions or diffusion of the ions is known as the equilibrium potential or isoelectric potential, right? Okay. Next question, an anion is having the following concentration. So this question, just read the questions, you will be able to understand that this is based on the Nernst equation just we have discussed. So according to the Nernst equation, equilibrium potential of an ion is equal to RTZF, okay, natural logarithm of concentration of the ion outside the cell and concentration of the ion inside the cell. I believe all of you know this, because here we are not going to discuss the detail of this. This is a kind of revision. This is a kind of revision. So here the formula, I believe all of you know that this R, T and F, these are the constant. Okay. So this ln is the natural logarithm of concentration of the ion outside the cell, concentration of the ion inside the cell. So if you simplify this, this will be equal to equilibrium potential is equal to plus 60 millivolt upon Z. So Z is the Z is the charge of the ion that we are going to write, log of concentration of the ion outside the cell and inside the cell. Now if you look at this question, so here it is given that 100 milliequivalent per liter in the ECF and 10 milliequivalent per liter in the ICF, right. So outside is 100 milliequivalent per liter. So obviously it will be EQ is equal to plus 60 upon minus 1, okay, anion. Okay, so we are taking it is minus 1 log of concentration of the ion outside the cell, concentration of the ion inside the cell, right. So this will be, this whole fraction will be equal to, I believe you know that this is log 10 base 10, how much it will be, this is 1 and this will be minus 60 millivolt or minus 61 millivolt. Okay, you can say 61, here I have written 60, some of the books are saying 61, some of the books are saying 63 also, that is absolutely true. So 60 or 61 is okay, but here it will be minus. Why minus? Because look at, even if you don't remember the formula, here which kind of ion is given, it is anion is given. So anion outside concentration is high is given. So whenever you are imagining that a cell is having an anion is high in outside the cell, so obviously the anion is going to enter inside the cell. So whenever one anion is entering inside the cell, which kind of potential is going to be generated? Negative potential. So obviously here the equilibrium potential cannot be positive, here it will be minus 60 millivolt. Got it? So everybody, so this answer is based on the Nernst equation. Typically this kind of question is asked in INI set, but you can also expect this kind of question in NEET PG also. Okay. Now next. So next is based on certain information which are very important for NEET PG. So there is a table here I have given. So this table you have to remember everything from this table. So here the question is asking that 125 iodine labeled with albumin. So albumin labeled with 125 iodine. This is used for the measurement of. So if you look at here in this table, so this is iodine tagged, okay, albumin. So this is typically for the measurement of plasma. And interstitial fluid, we know interstitial fluid cannot be calculated directly. You have to measure the ECF and you have to measure the plasma. So plasma is measured by this albumin, as well as the plasma is also measured by Evans blue. Okay, so these two names are very important, Evans blue and the iodine tagged albumin. Okay, along with that, the previous question has been asked based on this inulin, which is useful for the ECF volume measurement, and this D2O and tritium oxide and antipyrine. All this thing has been already asked in MCQs, but I am telling you, try to remember all of this thing what has been written here. Okay, so this is different substances used for measurement of the different fluid volume. Okay, ICF volume, ECF volume, total body water, how you are going to measure. Okay, so these are the substances that you have to measure. Okay. Now next is the, we are entering in the neurophysiology discussion. So first question, which ion is most responsible for resting membrane potential of the cell? Answer batao everybody. I believe all of you know this answer. Which ion is most responsible for resting membrane potential of the cell? So I got one answer. Yes, the answer is potassium. So potassium is the most diffusible ion in the resting cell membrane, followed by chloride, followed by sodium, and that's why potassium is mostly responsible for the resting membrane potential of the cell. Every cells in the body, almost every cells in the body. Okay. Now second question, in a 35-year-old patient due to intravascular hemolysis, serum potassium has increased to 5.5 milliequivalent per liter. So this is a kind of little hyperkalemia, mild hyperkalemia. So this is a hyperkalemic condition. So I told you that whenever hyperkalemia or hypokalemia is given and they are asking question on resting membrane potential, try to imagine like this, that normally RMP is due to movement of the potassium from in to out, okay, and this movement occurs through the leak channel. Okay, now whenever potassium concentration is high in the extracellular fluid, then what will happen to the normal movement of the potassium from in to out? This movement will decrease, and whenever this normal movement of the potassium from in to out is decreased, Okay, what will happen? More potassium is going to stay inside the cell. If more potassium is staying inside the cell, which kind of potassium you are going to generate? The positive potential inside the cell. So positive potential means in these cases there will be depolarization of the cell, right? So please remember, hyperkalemia means there will be depolarization of the resting membrane potential, and hypokalemia means there will be hyperpolarization of the resting membrane potential. Now hyperkalemia is causing depolarization. Depolarization is also known as decreased in RMP, decreased in RMP, and hyperpolarization is also known as increased in RMP. So whenever RMP is moving towards the 0 millivolt, then that is known as a decrease in RMP. It is going towards the 0 millivolt. The distance from the 0 millivolt is decreasing. But whenever the RMP is going in more negative direction, then it is going away from the 0 millivolt. So the distance from the 0 millivolt is increasing. That's why that is increased in RMP. So in case of hyperkalemia, the RMP decreases. What do you mean by decrease in RMP? Decrease in RMP means that is going towards a depolarization. Got it? So everybody, this is clear to all of you. Give me a thumbs up whether you got it or not. Okay. For the timing, you remember like this, that depolarization means decrease in RMP. Why? Because in this cases RMP is moving close towards the 0 millivolt. So from the 0 millivolt, the distance is decreasing. That's why decrease in RMP. Okay. And in case of hyperpolarization, RMP is going away from the 0 millivolt. Okay. Okay. Fine. Fine. Now next is the slowest conducting nerve fiber in our body. So all of us now, slowest conducting nerve fiber is which one? That is a C type of fiber. Okay. Slowest conducting nerve fiber is C type of fiber. C type of fiber. And C type of fiber means they are responsible for pain, okay, and temperature, slow pain and warm temperature. Along with that, this is postganglionic sympathetic fiber. So this has been asked already in MCQ, that slowest conducting type of fiber, option was there postganglionic sympathetic fiber. So this was in the option. Okay, pain, temperature as well as postganglionic sympathetic fiber is the C type of fiber. Okay. Then next question, absence of dystrophin. So see, these are the MCQ in nowadays they are asking in the NEET entrance examination. So this is very, very simple. From your medicine knowledge, from your physiology knowledge, everywhere you know that whenever it is absent, then it is Duchenne's muscular dystrophy, and if it is partially present, okay, a partially present or functional mutation, because of the functional mutation, if it is partially present, then it is Becker's muscular dystrophy. So Duchenne's muscular dystrophy and Becker muscular dystrophy. Okay, partially present means it is Becker's muscular dystrophy. Got it? Okay. Now next question is very, very controversial. Okay. So in skeletal muscle, DHPR RYR receptor are coupled by DHPR RYR receptor are coupled by, right? So here you remember that in case of skeletal muscle, this is mechanical coupling. So mechanical coupling or electromechanical coupling, okay. But parallelly you also remember that for cardiac muscle, this is electrochemical coupling or simple chemical coupling. Okay, very good, very good. So I told you repeatedly in my classes that in cardiac muscle this is electrochemical coupling, and for skeletal muscle it is mechanical coupling or electromechanical coupling is the better answer, right? So yeah, remember karo. Okay. Now next question, during muscle contraction, a detachment of myosin head from actin occurs due to. So during muscle contraction, actin myosin cross bridge formation occur. Now remember, in presence of calcium there is attachment, means cross bridge formation occurs in presence of calcium, but detachment of this cross bridge require adenosine triphosphate, and that's why whenever there is deficiency of the adenosine triphosphate in the cell, this detachment is not going to happen, and the rigor mortis occurs after death because of that only, that during muscle contraction, the cross bridge is formed by, because of the deficiency of the adenosine triphosphate, detachment is not happening, and that is the rigor after death, because ATP is deficient and the muscle contraction, muscle is remain in a contracted state. So here the detachment of the myosin head from actin require which molecule? Your answer will be that detachment occur in presence of adenosine triphosphate, and attachment occurs due to presence of calcium ion. So calcium ion causes cross bridge formation, attachment, and detachment occur due to adenosine triphosphate. Okay. Now next, sensation detected by Pacinian corpuscle. I will wait here a little bit and I will ask you, please type your answer. Two sensation, important sensation, write down for Pacinian corpuscles, which has been asked multiple times. After adenosine triphosphate attachment, the cross bridge will detach, and then the adenosine triphosphate will be broken down to adenosine diphosphate and all. So for that I have to discuss the whole cycle, but here I am not discussing that. Okay, maybe in other classes we will discuss. Pressure, very good, very good. So please remember that Pacinian corpuscle is located in the deep dermis, deep dermis. So whenever you give pressure, okay, pressure is a kind of sustained touch. So whenever you are giving pressure or deep pressure, that is best detected by Pacinian corpuscle. So Pacinian corpuscle is a kind of touch receptor, but which kind of touch Pacinian corpuscle is best detected by? The pressure, okay, deep pressure particularly, and second one is the vibration. Second one is the vibration. Got it? So these are the two things that you have to remember, that vibration and, okay, so vibration and your pressure. These are the two sensations that you have to remember. First vibration, that is also correct. Very good. So whenever you are writing first vibration, I believe you also remember the frequency. The frequency should be more than, okay, more than 200 hertz. Okay, so generally we say that not the pressure, the vibration one is the first vibration, means more than 200 hertz, because the other kind of vibration, suppose the vibration frequency is in and around 50 hertz, slow frequency vibration can be detected by Misnar's, okay, Misnar's corpuscle also. So that's why the Dr. Avinash has written that first vibration. Very good. So if the vibration, suppose the question is asking vibration is best detected by, your answer is Pacinian. But suppose the question is asking first vibration, again your answer is Pacinian. But whenever the question is slow vibration or the frequency is given, then your answer is Misna corpuscles, right? Okay. Now discriminative touch sensation. So discriminative touch sensation means basically this is, they are asking about tactile acuity. Question can be asked in variety of name. Tactile acuity or 2-point discrimination. 2-point discrimination. 2-point discrimination. Whatever is the question, your answer is only on all Merkel's disc. Okay, your question is only on one Merkel's disc. Right. Same for, there is a confusion, that same answer is for the Braille reading also. Braille reading is also done by Merkel's, disc, greater than Misner's. Okay, both are required. I have explained in my main lecture, okay, that why Braille's, for Braille's also and for 2-point discrimination Merkel's is the answer. Okay, so both the cases, whether the question is asking about the tactile acuity or tactile discrimination or discriminatory touch or 2-point discrimination, your answer is Merkel's. Okay, because they have the smallest receptive field. Okay, and for Braille reading also the point is required to be identified, so Merkel's is required, and also Misner's is also equally important, but if you have to choose only one, Merkel's is the best. Okay. Then next question, vanilloid receptor are activated by. So here the vanilloid receptor activated by, they are basically asking TRPV type of receptor, TRPV1 type of receptor. So this TRPV1 receptor we have read in a discussion of the nociceptor. So this vanilloid receptor is a kind of nociceptor, okay, TRPV1, transient receptor potential V1 receptor, V1. So this vanilloid receptor, okay, they are activated by, means they are asking about this TRPV1 receptor, and this TRPV1 receptor is activated by obviously capsaicin, okay, also activated by H+ ion, also activated by temperature greater than 43 degrees centigrade. So remember all of this. You may not get the capsaicin in the options, you may get H plus ion also. So H plus ion can also be detected by TRPV, vanilloid. So there TRPV, this V for the vanilloid receptor, okay. So they can be activated by capsaicin, H plus ion, temperature which is greater than 43 degrees centigrade. Got it? Okay, very good. Next, Golgi tendon organ senses which of the following? I believe all of you can answer this question. T for tendon, you remember this, and T for tension. Okay, so tension at muscle tendon is best detected by Golgi tendon apparatus, right? So this Golgi tendon apparatus and the muscle spindle, they are the receptor for proprioception, we all know. So the muscle spindle, okay, they can detect the velocity of the muscle. This has also been asked in a multiple MCQ, velocity of muscle and the length of the muscle. So velocity of muscles and the length of muscle is detected by muscle spindle. But the Golgi tendon organ means they can detect the tension in the muscles. Okay, very good, very good. So this muscle spindle is for the stretch reflex and Golgi tendon organ is for inverse stretch reflex. Very good, good. Okay. Now physiological mechanism physiological mechanism behind transcutaneous electrical nerve stimulation. So whenever you are giving transcutaneous electrical nerve stimulation, you are basically stimulating the A beta fiber and A alpha fiber. So these A beta and A alpha are the large diameter fiber. Whenever you stimulate this large diameter fiber, the pathway for pain will be closed at the level of spinal cord. Means the gate which is there at the level of spinal cord for pain pathway, that gate will be closed, and that's why this theory is known as the gate control theory. Gate control theory of pain, right? So physiological mechanism behind transcutaneous electrical nerve stimulation to prove pain relief. So pain relief mechanism, TRANS is given. Transcutaneous electrical nerve stimulation is given to reduce pain sensation. How you are reducing pain sensation? By closing the gate for pain pathway, and that gate is located at the dorsal root region of the spinal cord, and this gate is, how the gate is blocked? The gate is blocked by the large diameter fiber stimulation, and they are the A beta and A alpha type of fiber. So your answer is gate control theory of pain, right? Endocochlear potential is generally, we remember, plus 85 millivolt. This is the endocochlear potential, plus 85 millivolt. Okay. Neurotransmitter released by inner hair cell during depolarization. So whenever the pressure is raised in the inner ear, okay, there will be bending of the hair, okay, the bending of the cilia of the hair cells, and whenever there is bending of the cilia of the hair cell, we know that there will be depolarization of the hair cells. Okay, whenever there is depolarization of the hair cells, the hair cells will release neurotransmitter for the activation of the cranial nerves, okay, 8 cranial nerve, and that neurotransmitter is which one? The excitatory neurotransmitter glutamate, right? So remember, glutamate is the neurotransmitter. Yes. So for depolarization, the ions which is required for the depolarization of the hair cell is the potassium and calcium. Okay. So that you answer you are giving is potassium. That potassium is the answer for the, if the question is which ion is responsible for the depolarization of the hair cells, then your answer is potassium and calcium ions, right? But if the question is after depolarization, hair cells releases which neurotransmitter to produce action potential on the 8 cranial nerve, then your answer is glutamate is the neurotransmitter. So these two important information you have to remember. Okay. Next, Rensa cell inhibition is an examples of. So we all know that Rensa cell inhibition is a typical examples of feedback inhibition at the level of spinal cord. Feedback inhibition at the level of spinal cord, and it causes feedback inhibition of which neuron? It causes feedback inhibition of motor neuron. Okay, it causes feedback inhibition of the motor neuron. आएंगे, चिंता मत करो. Now next question आ जाओ, true about Brown-Sequard syndrome. So we all know that the Brown-Sequard syndrome is the hemisection of the spinal cord. So, whenever there is cutting of the one half of the spinal cord, we know that on the same side there will be same sided or ipsilateral damage of the dorsal column pathway, dorsal column, and the opposite sided damage of opposite side, there will be damage of spinothalamic tract. Okay, spinothalamic tract, mainly the lateral spinothalamic tract. So, we all know that whenever you are damaging the dorsal column pathway, okay, same sided dorsal column is damaged, means same sided proprioceptions, vibrations, 2-point discrimination, fine touch, all will be lost. So, dorsal column carries which sensation? That should be at your fingertips. Okay, that is the fine touch, proprioception, 2-point discrimination, vibrations. These are the sensation carried by dorsal column pathway. So, that will be lost. And opposite sided which sensation will be lost? Opposite sided spinothalamic tract, the anterolateral spinothalamic tract, and they are carrying which sensation? Temperature, pain, and crude touch and pressure. Okay. So, opposite sided crude touch, pressure, pain, temperature, and same sided proprioception, vibration, 2-point discrimination, these are going to be lost. Okay, fine. So, these are the things that you have to remember for Brown-Sequard syndrome. These are the things you have to remember. Okay. Now, this question has been asked recently. So, this is a kind of new question. Previously, we do not used to teach this kind of information, like which tongue papilla does not have taste bud. So, there are different types of papilla. Generally, we do not teach this, but this time they have asked it. So, your answer will be filiform papilla. So, this papilla is not going to contain any taste buds. The other kind of papilla like circumvallate papilla, okay, they are going to contain the taste buds, right. Now, another question is also asked from this taste sensation, that sour taste is mediated by. So, there are 5 different primary taste sensation. Among these, the sour taste is mediated by. This was one of the difficult question, I believe, in the NEET Physics, and the options was very peculiar. So, this TRP, the transient receptor potential, the channel that we are discussing in vanillin receptor, the similar kind of TRP, transient receptor potential, but here this is P3, not the V, here the P3. So, there are different channels for different types of taste sensation. I have kept this table for your purpose. So, you try to remember that taste sensation, 5 different types of primary taste are there. So, here it has been written salt, sour, and here umami, bitter, and sweet. Okay, I believe you know what is umami. So, that is the taste of the Ajinomoto. Okay, monosodium glutamate ka jo tasting, right. So, here it is written salt and sour is detected by ionotropic receptor. Ionotropic receptor means they are basically the ion channels. They are basically the ion channels. And metabotropic receptor means they are basically the G protein coupled receptor. G protein coupled receptor. Getting my point? So, this salt and sour, it is detected by ion channels, but this umami, bitter, and sweet is detected by G protein coupled receptor, which are there on the surface of our taste bud. Now, additionally, they are asking that salt is detected by which channel? The ENaC channel, epithelial sodium channel, right. The sour taste is detected by TRPP3. This is the question they have asked in this time, right. Apart from that, sour taste is also detected by ASIC, that is acid sensing ion channels, acid sensing ion channels, okay, ASIC, and also detected by TRPP3. Okay. And on the right hand side is written the G protein coupled receptor, which are detecting this umami, bitter, and sweet taste. So, what are the different types of channel you have to remember? For umami taste, okay, TR1 and T2R, T1R and T2R. Okay. For bitter taste, this is the So, here you have to remember the mainly the taste are detected by T1R and T2R. So, here umami is detected by T1R1 and T1R3. Okay. For bitter taste, this is T2R family, and for sweet taste, this is T1R2 and T1R3. So, there is a little difference, but as a whole you remember that metabotropic receptor means they are in the family of T1R and T2R. So, T1R and T2R, there are different sub variety, बट मोटा मोटा करके ध्यान रखो कि ये तीनों टेस्ट को डिटेक्ट करने के लिए T1R एंड T2R टाइप्स ऑफ चैनल्स आर रिक्वायर. But for detection of the salt, INAX channel is required, that is epithelial sodium channel, and for sour detection, TRP-P3 channels is mainly required. Okay, so these are the basic thing that you have to remember, because nowadays they are asking in this molecular level question sometimes. Okay, okay. Now next question. This is very easy question, but again look at the stem of the question. So a long stem. Okay, so don't get frightened in your exam. Just try to look at the question, what they are asking ultimately. After giving a long history, they are already told you the answer, that the patient is suffering from multiple sclerosis. So which cells are commonly affected in such conditions? So the multiple sclerosis is a kind of demyelinating disease in the central nervous system. Demyelinating diseases of the central nervous system. So demyelinating disease means myelin forming cells are going to be destroyed because of the autoimmune reaction, and this myelin forming cell in the central nervous system is oligodendrocyte, right. So similar kind of demyelinating disease also then in the peripheral nervous system, and all of you know the name of the typical disease is the Guillain-Barré syndrome, so where the Schwann cell is damaged. So the Schwann cell is damaged means demyelination of the peripheral nervous system, and the oligodendrocyte is damaged, that is the demyelination of the central nervous system, right. Okay. Now the processing of the short term to long term memory, you all know that this processing, conversion of the short term to long term memory occurs at the level of hippocampus, okay. Which area of the hippocampus? CA1 region of the hippocampus, not the amygdala, hippocampus, okay. Amygdala is related to the emotions component of our memory, right. So hippocampus is the area where short term to long term conversion occurs, and after conversion, if the question is that the long term memory is storage at which part of the brain, so your answer, if the question is storage of this long term memory, then your answer is cerebral cortex is the answer, then your answer is cerebral cortex, okay. So the neocortex or the cerebral cortex is the area where the long term memory information is stored. But if the question is that in today's class you are learning some information, so whenever you are learning something, okay, you try to recall those information by making some mnemonics, okay. So that is your working memory, that is your short term memory. But if you revise one thing again and again, the short term memory information will be converted into long term memory by some changes at the level of hippocampus, okay, and that changes is known as the plasticity of the hippocampus, is done by certain changes, and those changes, because of the changes of the hippocampus, ultimately the information will be stored in the neocortex for long duration, okay, and that is your part of the long term memory, fine, okay. Now next question, look at this, is a recent question in NEET PG. A patient was hit on the neck and some bone chips enter into the spinal cord from lateral aspect on posterior part of the spinal cord. Proprioception of which part of the body will be affected first? Very important question and very nice question, I should say. So there is an injury in the neck, and because of the injury some bone fragment has entered into the spinal cord, and in the options which was given, that which of the following sensation is lost, only the proprioception option was given. So which sensation is lost here? Proprioception. So whenever the question is proprioception, means it is the dorsal column which is going to be damaged, because proprioception is carried by the dorsal column, position sense, okay. So dorsal column, fine touch, proprioception, 2-point discrimination, vibration we are discussing. So proprioception means dorsal column is damaged. So dorsal column damage means, look at this diagram. So this is the dorsal column pathway, and this is the anterolateral column. So this is the anterolateral column region, and this is the dorsal column region, right. So means I can imagine like this, that the bony chip has entered from this side like this. This is the bone chips which is entering in the spinal cord. Now whenever it is entering in the spinal cord from lateral aspect, it is damaging the dorsal column. But look at the typical arrangement of the dorsal column. This is a diagram taken from anatomy book, okay, the Gray's Anatomy, where it is clearly written that the dorsal column is arranged in such a way that the cervical fiber is here and here is the sacral region fiber. Means if you go from the lateral to the medial aspect, first of all you are getting the cervical fiber, then you are getting the thoracic fiber, okay, and then you are getting the lumbar fiber and then the sacral fiber. So whenever the bony chip is entering in the spinal cord from the lateral aspect, dorsal column is damaged. But which fiber of the dorsal column is damaged? The fiber which is carrying the sensation from the cervical region. Cervical region fiber means they are the fiber which is carrying sensation from the upper part or arms of the body. So in this question your answer was upper limb. Okay, upper limb sensation is going to be lost, particularly the arm sensation. So there was 4 options. Among these 4 options, one option is there, that same sided proprioception from the upper limb or same sided proprioception from arm. So that is the best choice here. Getting my point? Everybody tell me. But if you look at the spinothalamic tract, anterolateral spinothalamic tract. So in anterolateral spinothalamic tract, sacral fiber is the superficial, then lumbar, then thoracic, then cervical. Means if the bony chip is entering in the lateral spinothalamic tract from here, so anterior region mein the bony chip is entering, then it is going to damage the fibers. Which fiber is going to be damaged here first? The sacral region fiber is going to be damaged first. That means there will be loss of pain temperature from lower part of the body, leg. Okay, so look at here, if the bony chip is entering in the posterior part of the spinal cord, then the dorsal column is going to be damaged. But immediately whenever it is entering, the first it is going to affect the cervical fiber, means upper limb sensation is going to gone, and dorsal column means upper limb sensation of proprioception, 2-point discrimination, vibration, fine touch, etc. But whenever it is entering in the anterior part of the spinal cord, okay, first it is going to damage the sacral region fiber, means the lower part of the body sensation is going to be lost. And which sensation? This anterolateral column, they are carrying which sensation? Pain, temperature, crude touch, pressure. Getting my point? Everybody tell me whether you get it or not. Important question. Okay, everybody tell me whether you get it. Here the contralateral will be there, bilkul, because this anterolateral spinothalamic tract, you know, all of them are crossing at the level of the spinal cord, and posterior column they are uncrossed up to the level of the medulla. So posterior column means same sided, and anterolateral column damage ho raha means that is coming from the opposite side, because all of you know that the anterolateral column means they are crossing at the level of the spinal cord only. Got it? Okay, very good, very good. Okay, chalo. Now the next question. A 65-year-old patient presented in the medicine OPD with resting tremor, rigidity and loss of facial expression. Again, this is a recent MCQ from NEET PG. So, very easy question, and the answer of this question is a basal ganglia. Okay, basal ganglia, because the patient is suffering from the Parkinsonism disease. No one is going to ask you this much of simple question maybe in future. Okay, but sometimes you are going to get. Okay, so don't think that it is coming in the NEET PG, this should be a difficult question. No, this kind of simple question is also they are asking in the NEET entrance. But another question was also asked, hemibalismus is due to lesion of the following structure. So, the basal ganglia, various structure lesions are there. So, we all know that the Parkinsonism disease means it is the substantia nigra. Nigrostriatal pathway is going to be damaged. But there are other nucleus which can damage, like for example, subthalamic nucleus is responsible for, when the subthalamic nucleus is damaged, hemibalismus is the disorder. When the striatum, the indirect pathway of the striatum is damaged, then the Huntington disease is going to happen, and the direct path of the striatum is damaged, then dystonia is going to happen. So, try to remember this few important information. So, dystonia, Huntington's, hemibalismus and Parkinsonism. So, here the subthalamic nucleus is the answer. Hemibalismus is due to subthalamic nucleus. Very good. Great, great. All of you are doing great. Very good. Okay. Now coming to the cardiovascular physiology. So when the heart rate is 70 beat per minute, cardiac cycle duration. So this is very simple question. So the duration of the cardiac cycle is determined by 60 seconds. That is a 1 minute. Within 1 minute, how much is the heart rate? Okay. So here 60 upon 70. So this will be equal to 8.875, something like that. Dekh lena jo hoga. Okay. So this is a kind of answer that you have to give here. Okay. Now, second question, resting membrane potential of the cardiac muscle fiber. Tell me what is the answer. Resting membrane potential of the cardiac muscle fiber. Tell me the answer. I'm waiting. Ji. Dr. Vishas, Dr. Singh. Hippocampus C1, huh? नहीं है. Now I am asking what is the answer of this question? Cardiac muscle, RMP. So Purkinje fiber and cardiac muscle. Very good. No, minus 70 is not the answer dear. So here very good. So this is minus 90, okay, millivolt. Minus 70 is for the neuron, okay. For skeletal muscle as well as for the cardiac muscle, minus 90 is the answer. Minus 90 for skeletal muscle as well as cardiac muscle. And for the smooth muscle, I told you repeatedly, minus 40 to minus 60. Minus 40 to minus 60, there is a range. But for cardiac muscle and skeletal muscle minus 90, for neuron minus 70. ठीक है, भूलना नहीं है. Now normal AV nodal delay, answer बताओ. Normal AV nodal delay, single liner question but important question. So how much time is required to cross the AV node? So cardiac conduction का बात हो रहा है. Cardiac conduction, action potential conduction हो रहा है AV node के through. AV node is the area जहाँ पे सबसे ज़्यादा delay होता है. We know maximum delay occurs is the level of the AV node. Slowest conduction of the action potential occurs at the level of AV node, atrioventricular node, and the normal delay is 100 millisecond. Very good, okay. So that is generally 60 to 125 millisecond is the range, but on an average 100 millisecond is the answer. Very good, okay. Now next question, C wave is the JVP is due to all of you know, because this is a recent question which has been asked in the NEET PG. So we know the A wave in the JVP is the atrial contraction, atrium contraction. The C wave in the JVP is the C for the cusp, okay, C for cusp. Cusp means bulging of the tricuspid valve, okay. So this is due to bulging of tricuspid valves towards the right atrium, bulging of the tricuspid valves towards the right atrium. And there is also a V wave. V wave is due to the venous return to the right atrium, venous return to right atrium, right atrium. So these are the three important information, yes, you have to remember, okay. Next, which scientific method is the basis of the thermodilution method used for the measurement of the cardiac output? So this is a question from the INI set, but still I have kept this question here because I believe this thermodilution method is known as the gold standard method for cardiac output measurement. Okay, although there is fixed principle, but this is known as the gold standard method for cardiac output measurement, right. So this thermodilution method is based on a principles, and that principle is known as Stewart-Hamilton principles. Stewart-Hamilton principles. Okay, so try to remember the name of this scientist. Stewart and Hamilton, they are the name of the scientist, and based on this name, the thermodilution method is based on the principles which was discovered by Stewart and Hamilton. That's why this is known as the Stewart-Hamilton principles. Okay, fine. Main site of peripheral vascular resistance, main site of peripheral vascular resistance. So the peripheral vascular resistance is similar to the systemic vascular resistance, okay. So the peripheral vascular resistance, okay, or systemic vascular. So I will write down here the TPR, नाम सुना होगा, TPR, total peripheral resistance, which is also known as the systemic vascular resistance, okay. So the TPR, total peripheral resistance or systemic vascular resistance, this is the resistance of the whole circulatory system except the pulmonary circulation. Pulmonary circulation को निकाल दो, बाकी जितना सारा blood vessels है आपका body में, if you add up the resistance of all of them, then that is known as the total peripheral resistance or systemic vascular resistance. Now all of them means within these vessels, aorta will be there, artery will be there, arterioles will be there, capillaries will be there, and venous system will be there. But among these all vessels, the maximum resistance to blood flow is at which region? That is the arterioles. Please remember that arterioles are the vessels where the resistance to blood flow is maximum. That's why it is said that if you calculate total peripheral resistance, it is the resistance of the all vessels in the body, but maximum resistance is due to which vessels? Arterioles. And that's why the answer of this question, that the main site of peripheral vascular resistance is arterioles. Got it? Okay. Fine. इसको भूलना नहीं है, arterioles. Capillary will not be the answer because capillaries are arranged in a parallel circuit. So whenever you add resistance in parallel circuit, फिजिक्स में हमको सिखाते हैं कि टोटल रेजिस्टेंस कम हो जाता है. सो इसीलिए capillaries are not the main site of the resistance to blood flow. The main resistance to blood flow is at the level of arterioles. Fine, okay. Now, carotid body baroreceptor is most sensitive. So, here basically they are asking that the baroreceptor is most sensitive to which blood pressure? Baroreceptor is activated by blood pressure. But again, this question is controversial, but please note down that controversy has been made by different books, particularly the Indian books. But Genong is writing that whenever the question is most sensitive, answer is pulse pressure greater than mean arterial pressure. Yes, change in pressure, constant fluctuation of the pressure, and which pressure is constantly fluctuating? Pulse pressure. So, pulsatile pressure, the pulse pressure is the most important for baroreceptor, whether it is carotid sinus baroreceptor और aortic arch. baroreceptor कहाँ पे होता है ना? ये जो आपको क्वेश्चन पूछ रहा है भाई यहाँ पे कैरोटिड बॉडी बैरोरिसेप्टर, हम लोग जानते हैं आर्च ऑफ एओर्टा में भी बैरोरिसेप्टर होता है, बट दोनों में से बिटवीन दिस टू व्हिच बैरोरिसेप्टर इज मोस्ट सेंसिटिव? कैरोटिड बॉडी. Okay, baroreceptor is most sensitive than arch of aorta baroreceptor also. But if I ask you that this baroreceptor is most sensitive to which blood pressure? It can be activated by pulse pressure, mean pressure, systolic blood pressure, diastolic blood pressure. All four types of blood pressure can activate the baroreceptor. But most sensitive to which blood pressure? Your answer is pulse pressure followed by mean arterial pressure. Okay, okay, very good. Now, next question, highest total cross sectional area. So, here the total word is very important and cross sectional area is also very important. So, why the question is asking cross sectional area लेके हम क्या करेंगे? हम लोग जानते हैं कि velocity of the blood flow is inversely proportionate to the cross sectional area A. So, this A here is the cross sectional area. A here is the cross sectional area. Okay. So, wherever the question is asking that in which portion of the blood vessel the cross sectional area is the highest, your answer is capillary. Your answer is capillary. Is very good. So, obviously, if I ask you that the blood flow velocity is lowest at which blood vessels, again your answer is capillary. But whenever I will ask you blood flow velocity is highest, okay, your answer will be arch of aorta. Your answer will be aorta, right? So, these are the things that you have to remember. Okay, very good. So, now here the Bainbridge and Bejold-Jaris. So, Bainbridge reflex and Bejold-Jaris reflex. So, Bainbridge reflex is the reflex related to the right atrium. पहले ये ध्यान करो, Bainbridge it is related to the right atrium and Bejold-Jaris it is related to the left ventricle mainly. So, this is mainly due to right atrium reflex mainly, and this is left ventricular reflex. Bainbridge reflex is a kind of reflex when the right atrium is stretched. So, what is the stimulus for this Bainbridge reflex? Your answer is stretch on right atrium due to any cause. Stretch on right atrium, maybe right atrium engorgement, right atrium dilation. In all these cases, Bainbridge reflex will be activated. Right atrium stretch. Okay, so the receptor is located in the right atrium wall. So, whenever there is stretching of the right atrium, the Bainbridge reflex will be activated, and whenever there is activation, what will be the response? The response is there will be increase in heart rate. That's all. There will be increase in heart rate. Okay. So, whenever Bainbridge reflex is activated, heart rate will be increased. Now, Bejold-Jaris reflex, it is a kind of chemoreceptor reflex, chemical reflex. So, you have to remember certain names. What are the chemicals that activate the Bejold-Jaris reflex? First of all, serotonin. Already the question has been asked from this serotonin. Okay. Veratridine, capsaicin, okay, and serotonin, veratridine, capsaicin, and phenylbiguanide. So, try to remember all of the four names because you never know which options is going to come in your questions. Serotonin, capsaicin already has been given in the MCQ. Maybe they will give you the veratridine and phenylbiguanide. So, whenever this kind of chemical is present in the left ventricular muscle wall, okay, through the coronary circulation, then the Bejold-Jaris reflex will be activated. And if the Bejold-Jaris reflex is activated, what is the response in the body? What will be the response if the Bejold-Jaris reflex is activated? There will be severe decrease in blood pressure, there will be severe decrease in heart rate. So, here there will be bradycardia and hypotension. So, in case of Bain-Briggs reflex, heart rate increases, but in case of Bejold-Jaris reflex, heart rate decreases, blood pressure also decreases. Along with that, there will be coronary vasodilation. Along with that, there will be apnea also. Okay, apnea also. So, at least we remember there will be decrease in blood pressure, there will be decrease in heart rate. Okay, so that is Bejold-Jaris reflex. Now, next question is Andreeff effect and Bowditch effect. So, these two effect has been asked in INI set exam, Bowditch and Andreeff. So, we know one effect that is known as the Frank-Starling law. So, Frank-Starling law में क्या बोला था कि whenever there is increase in end diastolic volume, the contractility of the heart increases. The contractility of the heart increases. This was the Frank-Starling law. This was the Frank-Starling law. Now, if there is increase in afterload, and increase in afterload is increasing the contractility of the heart, then that is known as the Andreeff effect. And if there is increase in heart rate is also increasing the contractility of the heart, then that is known as the Bowditch effect. Three effect. Okay. So, one is if there is increase in end diastolic volume or preload. End diastolic volume is also known as a preload. So, I believe you know that. So, increase in preload is increasing the contractility of the heart. So, this is known as the Frank-Starling law. So, this is known as the Frank-Starling law, contractility is rising. Now, whenever there is increase in afterload is increasing the contractility, that is Andreeff effect. And whenever increase in heart rate is also increasing the contractility, that is known as the Bowditch effect. याद रहेगा, ठीक है. So, ये तीन effect related to the contractility of the heart only. Okay. Now, the last line here, functions of HCN channel. So, all of you know from your pharmac knowledge that HCN channel is hyperpolarization induced CAMP nucleotide gated channel. Okay. And this channel is responsible for funny current. Okay. So, the funny current is there for nodal tissue action potential. Okay. There is a potential which is known as a pre-potential. So, basically the nodal tissue is producing spontaneous rhythm, and that is known as the sinus rhythm from nodal tissue. Sinus rhythm is maintained by HCN channel. Okay. So, HCN channel is also known as a funny current channel. Funny current channels, which ion is responsible for this funny current? Sodium ion and little bit of potassium ion, but mainly it is sodium ion. And this funny channel is responsible for maintenance of the nodal tissue rhythm, SA nodal rhythm. That's why I have written here sinus rhythm maintenance is done by funny current channel. Got it, everybody? Okay. Next, best index of afterload. So, just now we have discussed that afterload increment is known as the Andreeff effect. Best index of afterload is the mean aortic pressure, which is dependent on total peripheral resistance. So, if the question is best index of afterload, your answer is mean arterial pressure. Okay, mean aortic pressure or mean arterial pressure, but mean arterial pressure dependent on total peripheral resistance. So, both are related to afterload, but if you have to choose single best answer, that best index of afterload, then your answer is mean aortic pressure. But if the question is afterload depends on which of the following, afterload depends on which of the following, then your answer is total peripheral resistance. So, index, whenever the question is asking about the index means if you measure this index, you are going to get the afterload estimation. Your answer is MAP. But whenever the question is afterload is dependent on, then your answer is TPR. समझ में आ रहा है कि नहीं आ रहा है everybody? कहाँ गए सब लोग? Okay, इसका आंसर कैलकुलेट करो. What is the answer of this? When the cardiac output of a patient, calculate the cardiac output of the patient when the arterial oxygen is this, venous oxygen is this, whole body oxygen consumption this. So, which formula I am going to apply here? Which formula I am going to apply here? Fixed principles. Yes, very good. Fixed principle of cardiac output measurement. So cardiac output, according to the Fick's principle, what it is saying, the cardiac output is equal to the oxygen consumption upon your artery minus venous oxygen. Okay. So here it is 300 upon, this is 20 minus 16, 20 minus 16, 16 here, and this is in DL. DL means 100 ml. DL is deciliter, that 100 ml. So I have to multiply this with 100. So this is simple 300 upon 4. Okay, 7500 ml, that is 7.5 liter, right? 7500 ml. So जब भी कोई मैथ आता है ना, तो ये मेडिकल आने के बाद ना, सो मैथ के लिए दिमाग पूरा शट डाउन हो जाता है, तो इसलिए सिंपल मैथ भी आता है ना, तो मेरे को थोड़ा सा सोचना पड़ता है. सो आप भी एग्ज़ाम में थोड़ा सा कॉशसली करना, बिकॉज आफ्टर रीडिंग दिस फिजियोलॉजी, बायोकेमिस्ट्री, एवरीथिंग फॉर द लास्ट 5 to 6 ईयर, मैथ नॉलेज कम हो जाता है, ठीक है ना, थोड़ा सा सिंपल मैथ भी कभी कभी गड़बड़ हो जाता है. सो आराम से करना है एग्जाम में जब भी मैथमेटिकल क्वेश्चन आपको दिया जाएगा, ठीक है ना. ओके, चलो. Next question is related to the renal physiology. So glucose transporter presented on the apical membrane of the PCT. आंसर बताओ इसका. अच्छे से पढ़ो सेंटेंस को, देन आंसर बताओ. Glucose transporter present on apical membrane of PCT. ये क्या पूछा है, कौन सा मेम्ब्रेन पूछा है, एपिकल मेम्ब्रेन. ओके, सो मान लो आपका दोनों ही ऑप्शन में है, तो SGLT मारोगे कि ग्लूड मारोगे. क्वेश्चन पूछा है एपिकल मेम्ब्रेन. सो एपिकल मेम्ब्रेन मीन्स द मेम्ब्रेन व्हिच इज टुवर्ड्स द लूमेन ऑफ द नेफ्रॉन. ओके, सो लूमेन का डायरेक्शन में, और अदर मेम्ब्रेन को हम लोग बोलते हैं बेसोलैटरल मेम्ब्रेन. सो लूमेन के डायरेक्शन में जो होता है दैट इज द SGLT. सो दिस इज SGLT type 2 because it is PCT, proximal convoluted tubules. Okay, and on the basolateral membrane it will be GLUT2. ठीक है. So answer of this question is SGLT2. Fine. Okay, right. Now next question, percentage of glucose absorption. This is not a NEET PG question, which is present in the proximal straight tubule, PST. So PST means it is the late part of the proximal tubule, later part of the proximal tubule. No, क्वेश्चन सुनो, फिर से क्वेश्चन सुनो. सो जब भी आपको क्वेश्चन पूछा जाएगा कि परसेंटेज ऑफ ग्लूकोज एब्जॉर्प्शन इन द फर्स्ट पार्ट ऑफ द proximal tubule, then that is the 90%. 90% is the PCT, that is the first part. Okay, but here it is the late proximal tubule. Late proximal tubule means it is the proximal straight tubule, and here only 10% glucose which is remaining, that is going to be reabsorbed. And another thing, so this 10% glucose reabsorption here is done by SGLT1, and that is coupled with GLUT1. So in case of proximal tubules, ये जो 90% glucose reabsorption, this is done by this SGLT2. अच्छे से क्लियर करके ध्यान रखना है. So this 90% glucose absorption is done by SGLT2, right? That's why we say that main glucose reabsorption in the kidney is done by SGLT2, and that is the first part of the proximal tubule. Because इसलिए हम लोग जानते हैं ना कि ग्लूकोज जब भी फिल्ट्रेशन होकर ग्लोमेरुलस पे आता है, ओके, Bowman's capsule के बाद whenever it is coming to the PCT, within the first half almost all the glucose is reabsorbed, only later part is absorbing 10% of the total glucose filtrate. ठीक है. So in the later part of the proximal tubule, 10% glucose reabsorption is done by which transporter? SGLT1. And both SGLT1 and SGLT2, both of them are active transporter, they are the secondary active transporter. But whenever we are reaching at the level of GLUT, तो GLUT means that is facilitated diffusion. भूलना नहीं है, ठीक है ना. सो ऑप्शन में क्या दिया जाएगा आपको पता नहीं है. सो whenever it is present the SGLT, the basolateral membrane will contain GLUT1. It will be GLUT1. But whenever I am focusing on GLUT1 or GLUT2, they are the facilitated diffusion. Okay. but whenever we are thinking of SGLT2 or SGLT1, they are the secondary active transporter. भूलना नहीं है, and मिस्टेक नहीं होना चाहिए ये सब क्वेश्चन का, ठीक है ना, बिकॉज इफ यू आर डूइंग मिस्टेक इन दिस काइंड ऑफ क्वेश्चन, सो दैट इज अ काइंड ऑफ सुसाइड इन योर एग्जाम हॉल, आई एम टेलिंग you. Okay, because there are thousands of students who are going to make it correct, okay, and you are going to make mistakes. So make it clearly, absolute clear here. Now insulin dependent glucose uptake is seen in, okay, so we know that this is insulin dependent glutamine, that is the GLUT4, all of you know, and it is seen in case of skeletal muscle, okay. So skeletal muscle, smooth muscle, so I will write down muscle only. So muscles and adipose tissue. So muscle and adipose tissue, they are the site where the insulin dependent glucose uptake occurs, okay. So at least this much of information, very good. Fructose, no, fructose is not insulin dependent, na? Fructose transporter is the GLUT5, okay, but that is not insulin dependent, right, okay. Now in the next question, in the late portion of the PCT, luminal concentration increases for which ion? This has been asked in ionized recently. Answer is chloride ion. Because in the proximal part, sodium reabsorptions occurs with amino acid, phosphate, citrate, lactate, glucose, okay, all of these things will be absorbed along with glucose. But you all know कि जब भी सोडियम आता है ना तो उसके साथ साथ क्लोराइड भी फिल्ट्रेट हो जाता है. So sodium and chloride both has been filtered, but in the proximal part sodium is reabsorbed along with amino acid, phosphate, citrate, glucose. So क्लोराइड को कोई नहीं देख रहा है ना, तो क्लोराइड रह जाएगा. तो क्लोराइड रह जाएगा मीन्स लेटर पार्ट ऑफ द पीसीटी में क्लोराइड कंसेंट्रेशन बढ़ जाता है. सो दैट इज द रीजन, राइट, ओके. नाउ मैकुलर डेंसा सेल is the cells of which part of the nephron? Believe me, answer of this question is not DCT. Answer of this question is TAL, thick ascending limb of loop of Henle. Thick ascending limb of loop of Henle. Loop of Henle. So uppermost portion of the thick ascending limb of loop of Henle is the site where macular densa cells are located. If rarely this option is not given, then TAL and DCT junction is the best answer, but not the DCT alone, okay, TAL DCT junction. But previously this question was given and there the DCT was the answer, but nowadays they have asked this question recently and their DCT was not a single option. So TAL is the answer of macular densa cell, okay. Now erythropoietin act on or erythropoietin secreted by. So erythropoietin secretion, हम लोग जानते हैं कि एरिथ्रोपोइटिन सिक्रेशन किडनी एंड लीवर दोनों जगह से होता है. सो किडनी व्हिच सेल्स इज गोइंग टू सिक्रेट द एरिथ्रोपोइटिन? पेरीटिब्यूलर कैपिलरी एपिथेलियम सेल्स, राइट, एंड इन लीवर पेरीवीनस हेपेटोसाइट, here, okay, पेरीवीनस हेपेटोसाइट, right. And erythropoietin act on various cells during the RBC synthesis, but the most important cells on which erythropoietin receptors are maximally present is the colony forming unit of erythroblast. So that's why whenever they are asking question that erythropoietin major action on which cell, your answer is CFU erythroblast, CFUE, okay. It can also act on BFU also, blast forming unit, that is the first cell on which erythropoietin act, but that is not the main cells on which erythropoietin act, okay. First cells in the RBC series where erythropoietin is going to act is the burst forming unit, but if the question is major action of erythropoietin on which cell, then colony forming unit, right, okay. Renin is secreted by, all of you know the answer, JG cells, okay. So JG cells and renin and erythropoietin sometimes exam में confusion हो जाता है, so try to remember, okay. Next, flat portion of the cystometrogram. So here the cystometrogram has been given recently. So flat portion means this is the 1B portion, this 1B portion. We all know that in this 1B portion, why the pressure is not rising although there is increase in the volume of the urine. So urine volume is rising but the pressure is not rising. This is typically application of Laplace law, okay. This is typically application of Laplace law, got it. So, typical application of the Laplace law is at the level of bladder, and this is also the property of the plasticity. So, bladder को stretch करो तो it will change the shape. So, that is also known as the plasticity of the bladder. So, both are there, Laplace law and plasticity, both the term you should remember. And along with that, you also remember this question has been asked previously in INI set, that the first urge to void. So, first urge to void urine is felt at which volume of the urinary bladder? That is 150 ml. So, whenever 150 ml urine is present in your bladder, you will first felt a sensation that I have to pee. But whenever the volume is 400 or more, then that is the marked sensation you will feel for urination. These two information you have to remember, right? That's all. Okay. Now, which of the following glycoprotein is found in glomerular basement membrane? So, answer is heparan sulfate proteoglycan. Heparan sulfate proteoglycan, which is negatively charged, right? This information. Impaired function of aquaporin 2 in kidney causes. So, all of you know that this is nephrogenic diabetes insipidus. So, aquaporin 2 is the aquaporin which is stimulated by ADH hormone, antidiuretic hormone, right? So, these are the very simple information all of you know, I believe, because this is very crucial information, but look at, they are asking question from this crucial information only. Okay, that is why I was telling that most important information, the crucial information, they are asking question on that. Physiology questions are not very difficult in recent NEET exam, okay, but you have to revise the normal things only, normal thing, okay, and believe me, you are going to get the question. Very detail में physiology for NEET is not required, for INI set absolutely required, okay. Now, in respiratory physiology, in case of infant respiratory distress syndrome, there is deficiency of, all of us know that there is deficiency of surfactant, but surfactant was not in the option. The phospholipid which is making the surfactant, the most important phospholipid is the DPPC, dipalmitoyl phosphatidylcholine, which is also known as lecithin. This was in the option. So, DPPC or lecithin is the answer. Surfactant obviously, but the composition of the surfactant, mainly it is phospholipid, and which phospholipid is maximum? Dipalmitoyl phosphatidylcholine, DPPC or lecithin. These two important information remember. Okay. What happens to the surface tension and compliance in case of hyaline membrane disease? So, the same question. Infant respiratory distress syndrome, which is also known as the hyaline membrane disease. What happens to surface tension? What happens to compliance? So, there is deficiency of surfactant. Surfactant deficiency means lung will not be able to expand properly, means expansion of the lung is reduced, and compliance is nothing but change in volume, expansion, how easily the change of volume is occurring, how easily the structure is expansile, that is the measurement of compliance. So, compliance means stretchability, okay, the how much easily the structure is stretchable. So, whenever the hyaline membrane disease is happening, means surface tension is deficient. So, what will happen to the surface tension? Surface tension will increase to a very high level, okay. So, the surface tension increases, and if there is increase in surface tension, what will happen to the compliance? Compliance will decrease, right. So, surface tension increases because surfactant reduces the surface tension. So, if the surfactant is not there, so surface tension is going to increase, and if the surface tension is increased, then the structure will not be able to expand easily, means compliance is reduced. That is the thing you have to remember, okay. So, compliance decreases, surface tension increases, fine. If the lung was allowed to recoil, so this two line you read and try to answer. So, first line was already asked in INI set, second line I have made that if the question is given in another form. So, in the first line they are saying arteriosclerosis hoga to arterial compliance will be decreased, that is there. If the structure is hard, if the structure is stiff, then the reduced compliance is there, and if the structure is loose, lax, okay, then the compliance is high, that is the bottom line, okay. So, now if lung was allowed to recoil without chest wall, means you have to imagine that if you open the chest wall, if you remove the chest wall, so what will happen? Lung will get collapsed. But even after full collapse of the lung, what is going to happen? Some volume will still remain inside the alveoli which are collapsed, and that volume, what is the name? Very good, very good. Okay. So, here there will be full collapse of lung. So, here your answer is full collapse of lungs. But even after full collapse, the volume which is remaining inside the lung is known as the minimal volume. Very good, minimal volume, which is approximately 500 ml. Fine. Now, the second question, if the chest wall is allowed to recoil without the lung, first you tell me, if you remove the lung, chest wall will recoil. It will recoil in the outward direction or inward direction. What is the inherent tendency of the chest wall? It will expand, recoil in the outward direction or inward direction. First you tell me that. Okay, outward direction. And outward direction, chest wall will expand, 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 and then it will stabilize at a volume. So, in the first question, we are saying that if the chest wall is removed, lung will go for collapse, 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 and minimal volume will present, that is 500 ml. If I remove the lung, chest wall will expand, 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 it will go towards the expansion, and maximum expansion that is possible without any inspiration, is 70% of the TLC, 70% of TLC. It will not reach up to TLC. For expansion up to the level of TLC, you have to take inspiration. That's why the question is asking that during expiration, okay, that how much expansion of the chest wall is possible if the lung is not there. So, basically we all know that when the lung is at resting condition, मेरे को पहले ये बताओ, resting condition means कितना volume lung में होता है? When the lung is in resting condition, the volume which is present is known as the FRC, functional residual capacity. From the functional residual capacity, if you remove the lung, chest wall will expand, and how much expansion is possible? It will go for expansion and it will reach up to 70% of the total lung capacity. From the FRC, if I remove the chest wall, lung will collapse, and whenever it is collapsing, it will go to a very small amount of volume, that is known as the minimal volume, which is approximately 500 ml. Getting my point? Okay. So, you remove the lung from the chest wall will expand. How much expansion maximally possible? 70% of the TLC. And you remove the chest wall and lung will collapse, and after collapse, how much volume is going to remain in the lung? 500 ml. That is minimal volume. Everybody tell me whether you get it or not. Important. So, when both lung and chest wall is intact, it will remain in a resting condition, and that is FRC, right. From the FRC, expansion may happen or collapse may happen. ठीक है? Okay. Now, FRC is the volume which remain in the lung after. So, we all know that FRC is equal to residual volume plus your functional, okay, बोलो functional नहीं, residual volume plus expiratory reserve volume, यही ना. So, FRC means residual volume is also there in your lung plus expiratory reserve volume is also there in the lung. So, this volume will remain in the lung whenever you hold your breath at the end of normal expiration. Very good, doctor. Okay. K, that is at the end of ये दिखाई नहीं दे रहे, at the end of normal expiration. At the end of normal expiration, if you hold your breath, at the end of normal expiration, if you hold your breath, then that volume is known as the FRC, because in that condition, expiratory reserve volume will also stay in the lung and your residual volume will also stay in the lung. Next question, rhythmicity of respiration is maintained by. So, in case of heart, we have seen SA node is producing the rhythmicity because of the funny channel. In case of lung, the respiratory center is located at the level of medulla, and medulla contain two important center, one is the VRG and one is the DRG. So, this VRG contain one important area which is known as the pre-Bötzinger complex. pre-Boettinger complex of neuron. So this pre-Boettinger complex of neuron is known as the pacemaker of respiration. Pacemaker of respiration. Getting my point? So that's why whenever the question is rhythmicity of respiration is maintained by or pacemaker of respiration, your answer is same. That is the pre-Boettinger complex, which is a part of the ventral respiratory group of neuron, right? Any stimulus which is coming at the level of ventral respiratory group, if you stimulate the ventral respiratory group of neuron, then your respiratory rate and depth is going to be increased. So if the question is during exercise, okay, rapid breathing, so respiratory rate is rising. So obviously you have to stimulate which part of the respiratory center? Ventral respiratory group of neuron. Okay. Next is anatomical dead space is calculated by. Answer is single breathe nitrogen wash out method. Single breathe nitrogen wash out method is also known as Fowler's method, right? Single breathe nitrogen wash out method is also known as Fowler's method. Okay. Now ventilation perfusion ratio is maximum at apex. Ventilation is maximum in the base, perfusion is also maximum in the base, but ratio between them is maximum in the apex. This thing, ventilation is also maximum base, perfusion is also maximum in the base, but ratio between them is maximum in the apex. VQ ratio is infinity. VQ ratio is infinity when? So V upon Q is infinity, means when the ventilation is normal but perfusion is 0, then the ratio will be infinity. Okay, obstruction. Okay, so here I have kept this diagram. So this is the typical diagram where this is the alveoli, this is the alveoli, okay, and this is the blood supply to the lung. Okay, if you block this, if you block here, suppose there is a blockage here, okay, blockage. Suppose there is a blockage here. So that is the blockage of ventilation, foreign body, tumor, anything which is blocking the ventilation. So here the VQ ratio will be, ventilation is 0, perfusion is normal, so VQ ratio is 0. Okay. So getting my point. So whenever there is a blockage of the ventilation, then the VQ ratio is 0. When the VQ ratio is 0, I will not explain the detailed phenomena, but you remember in this condition this alveoli will have composition of gas which is similar to the venous blood gas composition. What is the venous blood gas composition? Partial pressure of oxygen will be equal to 40, partial 40, yes, 6940, and partial pressure of carbon dioxide will be 46. So whenever VQ ratio is 0, okay, alveolar gas composition will be similar to venous blood composition. Oxygen is 40, carbon dioxide is 46. But now suppose one embolism is blocking the perfusion, means if there is blockage of this blood supply to this alveoli, then what is happening here? The ventilation is normal but perfusion is 0, means the VQ ratio is infinity. Whenever the VQ ratio is infinity, the composition of the alveolar gases will be, partial pressure of oxygen will be 149 millimeter of mercury and partial pressure of carbon dioxide will be near equal to 0, that is 0.3 millimeter of mercury. Okay. So try to remember that whenever VQ ratio is infinity, in these cases composition of the alveolar gases, oxygen will be very, very high, carbon dioxide will be very, very low, and whenever the VQ ratio is 0, oxygen is very low, carbon dioxide is very, very high. Okay. So these two important things you have to remember about the VQ ratio. Okay. Next, at high altitude of 3000 meter, a person complains of breathlessness. Okay. Which can be used, all can be given, so except. So except wali question means you have to look at the options, but here the person is most probably suffering from high altitude pulmonary edema, HAP. Okay, high altitude pulmonary edema. Also you know okay, that is acute mountain sickness, okay, acute mountain sickness and high altitude cerebral edema. Okay, so in all of this condition, the basic treatment protocol is that you have to give oxygen supplement, right, and you have to also descend to a low altitude, okay, to improve the oxygenation. Along with that, you can give acetazolamide, but acetazolamide best act when it is given as a prophylaxis. But again we give acetazolamide because again ultimately you have to adapt there, adaptation is required. So, acetazolamide is also given, and I believe that you know that for this HAPE, the specific treatment which is given is a calcium channel blocker like nifedipine, right? And for HAPE and HASE, the specific treatment which is given is a corticosteroid. But general treatment which is given for both the disorder, all three disorder, is the oxygen supplement you must have to give, descent to the low altitude. These are the most important treatment. Along with that, acetazolamide पहले दे देना चाहिए because ultimately आपको adaptation होना ही जरूरी है. But specific treatment, if there is severe HAPE, तो nifedipine should be given, and if there is acute mountain sickness which is turning into high altitude cerebral edema, then sometimes corticosteroids can also be given. Okay, but question here is except, and in the choices digoxin was there, so answer was digoxin in this question. Digoxin is not given for HAPE, HASE or anything. Okay, high altitude disorder mein digoxin is not given. Okay, so that is the answer. Now next is the hyperventilating hysterical woman presented with carpospasal spasm. So this is basically a tetany, case of tetany. So we all know that whenever you do hyperventilation, it will leads to alkalosis. Alkalosis causes precipitation of the tetany. Why? Because alkalosis causes decrease in free calcium level in the blood. Free calcium level in the blood. Could you tell me why? Alkalosis जब भी होगा free calcium level in the blood में decrease हो जाता है. Because you know कि जो हमारा plasma protein होता है ना, plasma protein. So plasma protein contain which kind of charge? Negative charge. Now this negative charge of the plasma protein is always attacked by positive charge of the H plus ion and the positive charge of calcium. Both are the competition. कि प्लाज्मा प्रोटीन में जो नेगेटिव चार्ज बैठा है ना, बोथ ऑफ देम आर कॉम्पिटिटिंग. ओके, H plus ion and calcium, both of them are competing. Now whenever H plus ion is high in the blood, means acidosis, then H plus ion will remain attached with this plasma protein and calcium will remain free in the blood, means calcium concentration in this condition will be higher. But whenever the person is suffering from alkalosis, अब क्या हो जाएगा? Alkalosis means H plus ion has been reduced in the blood. So H plus ion reduced means this negative charge of the protein will be occupied by positive charge of calcium, means most of the calcium will bounce with protein. Calcium is not free, calcium is bound with protein. So what will happen to the free calcium level? Free calcium level decreases, and that free calcium level decrease means nerve fiber will be more sensitive to stimulus, and whenever nerve fiber is more sensitive to stimulus, there will be spasm of the skeletal muscle due to strong contraction, and that spasm is nothing but known as the tetany. So this carpospasal spasm which is happening due to increased sensitivity of the nerve fiber due to decreased calcium, okay, and due to increased sensitivity of the nerve fiber is stimulating the skeletal muscle contraction is happening, and that is spasm. Okay, so basically the answer here is hyperventilation is causing tetany precipitation due to decrease in free calcium. Why there is decrease in free calcium? Because hyperventilation will causes alkalosis. That's all. Okay, fine. Next question, a 50-year-old patient with respiratory distress, FEV1, FVC has been given. So whenever this kind of question you are getting, FEV1 upon FVC ratio you have to calculate. So here 1.5 upon 3.5 if you do, I believe this is 42 or something percentage will be there. So FEV1 FVC 42% means normal is generally okay 80%. So 80% से बहुत नीचे आ गया, 50% से भी नीचे आ गया. So it is typically of which kind of disease? Obstructive kind of disease. Right? Very good. Now peripheral chemoreceptor are sensitive to hypoxia via which of the following channel? This is a pet question of NEET PG. Okay, peripheral chemoreceptor, that is the carotid body and aortic body. Okay, so carotid and aortic body, right? Carotid and aortic body contain a channel which is known as oxygen sensitive potassium channel, and because of this presence of oxygen sensitive potassium channel, the carotid body and aortic body can senses the chemicals like carbon dioxide, H plus ion, all these things. So peripheral chemoreceptor are activated due to presence of certain chemicals, due to presence of one channel on the carotid body and aortic body, and that channel is oxygen sensitive potassium channel. That's all you have to remember. Okay, very good. Now from the GIT, highest frequency of BER is seen in. So here you have to remember the rate of the BER in different part. So answer of this question is duodenum. Answer of this question is duodenum, which is 12 per minute. But you try to remember all of the rate. So stomach has a rate of BER 4, right? Then duodenum is 12, jejunum. Jejunum is around 11, ileum is around 8, okay. Then cecum is generally 2, sigmoid colon is generally 6, okay. So these are the various rate that you have to remember. So from this rate I can easily understand the maximum rate is duodenum, but you never know, maybe duodenum is not in the choices, then jejunum will be the answer, okay. So this way you try to remember all of the rate, okay. So now this basal electrical rhythm or basic electrical rhythm is also known as the slow wave of the GIT. So this is also known as the slow wave of the GIT, and slow wave of the GIT is generated by one pacemaker cell in the intestine, that is known as interstitial cells of Cajals, right, or Cajals, interstitial cells of Cajals. Then next question, migratory motor complex reappear at. So migratory motor complex, it appear after 90 minutes of fasting. So if the question is also appear, then your answer is also 90 minutes after last food. So here the answer is 90 minutes. Again, if the question is reappear at an interval of, then also answer is 90 to 120 minutes. 90 minutes is the best answer, 90 to 120 minutes. So both the cases, if the question is migratory motor complex, which is a fasting motility, appear after how much time of fasting? 90 minutes fasting होनी चाहिए minimum, okay. And एक बार MMC appear हो गया तो दोबारा MMC आने के लिए there is a gap of time, and how much that time gap is 90 minutes, right. Then next question is highest concentration of potassium is seen in. Whenever the question is concentration, be careful, it is the colorectal secretion, colon and rectum secretion. But whenever the question is highest potassium amount, highest amount of potassium is seen in which secretion, then your answer is saliva. Saliva contain concentration which is high but not the highest, okay. Colonic secretion contain highest amount of concentration of potassium, but amount is not high because volume of colonic secretion is very less, and salivary secretion volume is also higher and potassium concentration is also higher, but not the highest concentration. But if you combine these two, then the total amount of potassium secreted by which gland, which is maximum, is the salivary gland. Salivary gland secrete maximum amount of potassium per day, okay. But concentration answer is colorectal secretion. High flow, low flow, that is for the depending on that, but whenever the flow is low and high, that you know, all concentration of all the ions will be higher except potassium. So that is there, but as an average, okay, normally suppose you are taking normal food and all, so total amount of potassium secreted by maximum which gland, that is the saliva answer, okay, salivary gland. Now next question, late emptying of gastric content due to presence of hypertonic and acidic content. So hypertonic acidic content, whenever it is present in the duodenum, it will produce a nervous reflex which is known as the enterogastric reflex. And because of this enterogastric reflex, there will be contraction of the pyloric sphincter which will prevent the gastric emptying, okay. So this enterogastric reflex, this question has been asked recently in NEET entrance examination, okay. Then which of the following substances causes anterograde relaxation? So anterograde relaxation is done by, okay, BIP, anterograde, okay, nitric oxide and adenosine triphosphate. But if the question is retrograde contraction then your answer will be ACH, acetylcholine and substance P. Very, very pet question in NET entrance examination. So, peristalsis means we all know there will be contraction in the retrograde means proximal part and there will be relaxation of the distal part. So, relaxation is done by adenosine triphosphate, nitric oxide VAP, and contraction is done by ACH and your substance P. Okay, very good, very good. Okay. Serotonin is released by the epithelial cells and that will ultimately causes this kind of scenario, proximal contraction, distal relaxation. Serotonin is the mediator of this, but serotonin is not causing this relaxation and contraction. Okay. Now here the endocrine, that is the last part. IGF act through which kind of receptor? We know that this is the tyrosine kinase kind of receptor. So previously you used to remember tyrosine kinase receptor, but nowadays they are asking that tyrosine kinase receptor also act through certain messenger system. Okay. And what are the hormone that act through tyrosine kinase receptor? So, this is a very open-ended question. There are many, but I tell you that try to remember this table, very, very important. So, I told you that tyrosine kinase receptor means it can act through the MAP kinase pathway also, it can act through the RAS-RAP pathway also. Till date, they have asked the MAP kinase pathway. So, which hormone act through this MAP kinase pathway? Your answer is insulin and insulin like growth factor 1, right. But if the question is which hormone act through this RAS and RAP pathway, your answer is EGF, epidermal growth factor and nerve growth factor. So, getting my point. So, tyrosine kinase means ultimately it can act through the MAP kinase pathway also, or it can act through the RAS-RAP pathway also. Okay. And different hormone act through this, but all of this hormone which is written here, they act through the tyrosine kinase receptor pathway. Fine. Okay. Now there are other receptor which act through this JAK-STAT pathway. This is also been asked in NEET entrance examination. The typical name is growth hormone and prolactin, JAK-STAT pathway. Okay. And there is another pathway which has not been asked till date, SMAD pathway. What are the hormone? Activin, transforming growth factor beta, and MIS, Mullerian inhibitory substances. These are the hormone which act through the SMAD pathway, right. So, this table is very, very important for any of the exam, whether it is INI set or NEET. Try to remember. Okay, fine. And this table, sometimes the G protein coupled receptor is also asked, but I am not asking you to remember all of them. Only try to remember the hormone which act through this GQ type of G protein, because this GQ ultimately stimulate the IP3-DAG and IP3 releases calcium inside the cell. So, there was an MCQ that which of the following hormones uses calcium at the second messenger. So, jitna hormone यहाँ पे लिख के रखा है, these are the hormone which act through calcium as a second messenger system, and this name you have to remember, right. बाकी दोनों column बाकी दोनों row you may not remember, but at least you remember GQ mediated hormone. Okay. Yes, oxytocin is also there, that has been asked directly. Oxytocin acts through each of the following. Okay. Now, a person presented with puffy skin and lethargy, his TSH levels are low and improved on administration of TRH. So, which type of hypothyroidism this is? Okay. So, we generally remember like this, that primary hypothyroidism means, so obviously this is a kind of hypothyroidism, right. Primary means here the thyroid gland is destroyed. So, thyroid gland destroyed means thyroid gland secretes T4 hormone and T3 hormone. So, T4 hormone will be reduced, but whenever T4 hormone is reduced, TSH and TRH will be higher. This is the typical scenario. Okay. Now, whenever I say that secondary hypothyroidism, then here the pituitary is problem, pituitary is destroyed. So, pituitary destroyed means pituitary secrete which hormone? TSH. So, TSH will be reduced. If the TSH is reduced, so TSH will not be able to stimulate the thyroid gland, so T4 will also reduce. Okay. But in this cases, TRH will be higher, right, TRH will be higher. And in case of tertiary hypothyroidism, the problem is at the level of hypothalamus, which is secreting the TRH. So, first thing that is going to happen is decrease in the TRH. If the TRH is not there, then TSH will also reduce. If the TSH is reduced, T4 will also reduce. So, look at here. In tertiary hypothyroidism means, okay, Tertiary hypothyroidism means all three hormones T4, TSH, TRH all are reduced. In these cases of tertiary hypothyroidism, if you give injection of TRH, so you are giving external supply of TRH. So in these cases TSH is supposed to rise because there is no problem in the pituitary. Where is the problem? Problem here is at the level of hypothalamus. So hypothalamus secrete which one? TRH. So TRH is low, that's why the problem of hypothyroidism originating. So if you give supply or injection of TRH from external sources, TSH is going to rise because pituitary is not a problem. So whenever the TSH is rising in response to TRH means pituitary is not problem, and TSH is rising the T4, then also thyroid is not a problem. So the typical question that has been asked here, that TSH is low but it is improved on administration of TRH. This is not going to happen in case of secondary hypothyroidism. You may be thinking that why not secondary? Secondary hypothyroidism also TSH is low. So the question here that is given, TSH is low means it can be secondary hypothyroidism also, tertiary also. But after injection of TRH, the TSH is improved. This is not going to happen if the pituitary is damaged. So secondary is not the answer here. So answer here is the tertiary hypothyroidism. Tertiary hypothyroidism due to problem at the level of hypothalamus is the answer of this question. Everybody tell me whether you get it or not. Everybody tell me whether you get it or not. Option was there primary, secondary, tertiary hypothyroidism. Okay. Or option can be given like this: hypothyroidism due to thyroid problem, hypothyroidism due to pituitary problem, hypothyroidism due to hypothalamic problem. Okay. So your answer will be hypothyroidism due to hypothalamic problem. We will have this kind of scenario. Okay. Fine. Now next question, damage of the pituitary stalk during surgery causes increase in which of the following? All of you can answer that prolactin is going to rise because prolactin is normally under inhibitory control from hypothalamus, right? So no discussion required. Hormones which are under inhibitory control from hypothalamus, so the same answer. So prolactin as well as the growth hormone. So growth hormone there is an inhibitor from the hypothalamus and that is known as the somatostatin, right? So here the answer will be both. The hypothalamus is inhibitory, prolactin is only inhibitory. For growth hormone, stimulatory is also there and inhibitory is also there. So answer here is prolactin and growth hormone both. Okay. Which hormone has permissive role in puberty? So we know the meaning of the permissive role. Permissive role means it directly cannot initiate the puberty, but it can help the other hormone for the onset of puberty. That is known as the permissive role, and the typical answer for permissive role during puberty is leptin hormone, right? Leptin is the answer of this question. And the last two questions for today's session, I have already written the answer because I believe all of you know the answer of this question. So after ovulation, corpus luteum increases which of the following hormone? Corpus luteum produces progesterone. And in male, testosterone is secreted from which cells? Leydig cells. All of you know this, and this has been asked in NEET PG in recently. Okay. So very simple question, but try to be cool in exam and try to give correct answer. Okay, because again I am telling, if you are making simple mistake in this kind of question, then you are not going to get good rank. Okay. So with this discussion I am finishing the session here. So I believe most of the important question that has been asked from the last 3 to 5 years that has been discussed in this session. So you just try to give a revision, so your job will be done. Okay. So that is all for today. Thank you so much for listening and best of luck for your exam. Okay. Thank you. Bye bye. Take care. Good night.